Morning, everyone. My name is Michelle Anyo. Sorry for the delay. We're experiencing a bit of technical glitches. So I will be talking on stroke and prevention, the symptoms, and all that. So according to the World Health Organization, stroke is defined as an accident in the brain with rapidly developing clinical signs of global disturbance cerebral function with symptoms lasting 24 hours or longer or leading to death. Basically, all that grammar was just trying to say that stroke is what we in the medical field sometimes tend to refer to as a cerebrovascular accident that happens to the brain that disturbs the cerebral function, and the symptoms can last 24 hours or longer, and in the very critical situations can lead to death. Some school of thoughts tend to believe that cerebrovascular accidents, or CVA, as we tend to call it sometimes, is not a preferred term, especially by neurologists. They tend to believe that stroke is not an accident, that the more meaningful term is a brain attack, like in the terms of like a heart attack. So everyone with their school of thought. So a stroke occurs when there's an interruption of the blood supply to a particular area of the brain, ultimately leading to cell injury and death. So there are types of stroke. Basically, there are two different types of stroke. There is the ischemic stroke and there is the hemorrhagic stroke. The ischemic stroke is caused by insertion of blood flow to a certain area of the brain. Ischemic stroke accounts for 85% of all acute strokes. So basically, of the two types of strokes, we commonly see ischemic stroke more compared to the second one, which is the hemorrhagic stroke. Ischemic stroke is an interruption of blood flow to a certain area of the brain, while hemorrhagic accounts for 15% of acute stroke and is caused by the bursting of a blood vessel. That's like acute hemorrhage. So for ischemic, something actually comes and blocks the blood vessel. While for hemorrhagic stroke, there's a bursting of the blood vessel. That is the difference. Then regardless of the type of stroke, it's important to know that with each minute of stroke untreated, close to 2 million neurons die. So basically, that's where the concept of time is brain comes about, because basically, the longer, or let me say, like the more time you delay, the more damage that occurs. So basically, the time is brain concept is as a matter of like what happens when stroke happens. Then ischemic stroke, like I said before, accounts for 85% and is the most common stroke. It occurs when there is an occlusion of a blood vessel, impairing the flow of blood to the brain. That is basically the blockage of the blood vessel, like I said earlier. Now, ischemic stroke itself is divided into like four. There is the thrombotic, that's a blood clot that forms in a major brain artery or within small blood vessels in the brain. So basically, like the way the brain is structured, there are arteries running around that do their normal daily duties of like carrying blood flow and bringing them back. So basically, when there's a blood clot forming in any of these arteries, a myriad of things can cause this blood clot. We'll still get to that later on. So when there's a blood clot somewhere in any of these main arteries or somewhere within a blood vessel deep inside the brain, that can lead to ischemic stroke. So that's the thrombotic ischemic stroke. Then there is the embolic type of ischemic stroke. This one is a blood clot or a fat globule that forms within a blood vessel elsewhere in the body. And then this blood clot that has formed somewhere else is carried to the brain. So basically, like the arteries now, they do their normal work of like carrying blood and moving them. So it's possible that a blood clot forms somewhere else and then it is carried to the brain. So that is the embolic type of ischemic stroke. And then there's a systemic hypoperfusion. That one is a general decrease in blood supply occurring in small vessels caused by arteriosclerosis. Basically, arteriosclerosis is a vascular disease where the blood vessels carrying oxygen away from the heart, that's the arteries I was talking about, they become damaged from factors such as high cholesterol, high blood pressure, diabetes, and sometimes certain genetic influences can lead to arteriosclerosis. So when this arteriosclerosis happens, it can cause systemic hypoperfusion. general decrease in blood supply, and then there's venous thrombosis. Then the second type of stroke, that is the hemorrhagic stroke. That one occurs when a blood vessel in the brain ruptures and bleeds. Remember, I said this one is like 15% of general like stroke. So it's not as common as ischemic stroke, but this one is a bursting of the blood vessel in the brain. They are divided into two. There is the intracerebral hemorrhagic stroke. That is bleeding from a blood vessel within the brain. While there is the subarachnoid hemorrhagic stroke. That's bleeding of a blood vessel between the surface of the brain and the arachnoid tissues that cover the brain. So the intracerebral hemorrhagic stroke, high blood pressure is the main cause of this one. So the high blood pressure leads to the bursting of the said blood vessel within the brain. Epidemiology of stroke. This basically refers to how often does stroke happen. Then according to the World Health Organization, 15 million people suffer stroke worldwide. That was the data as of 2018. And of these, 5 million die, and another 5 million are left permanently disabled. So basically, it's a 1/3 statistics. The 2010 Global Burden of Disease Study suggested stroke is the second leading cause of death globally, and the third leading cause of premature death and disability. Etiology. Many etiologies can lead to stroke. Some of the most common risk factors include what everybody knows as hypertension. That's basically a condition in which the force of the blood against the artery walls is too high. That's what we know as like high blood pressure. When the force of the blood against the artery walls is too high, that's why this particular one leads to hemorrhagic stroke. Because when the force of the blood against the artery walls are too high, and then there's a bursting of the blood vessel. Then there is also diabetes, is also a predisposing factor to stroke. And then there's the hypercholesterolemia. That's high amounts of cholesterol in the blood. And high cholesterol can limit blood flow because it can form fat globules and then increasing the risk of a heart attack. Basically, when these fat globules are transported by another artery to the brain. And then when it comes to hypertension, the normal range is what we know as 120/80. So hypertension is when you're having a blood pressure that is from 140/90 and above. And then when it gets to a 180/120, then that is the severe one. And then there's also the cerebral emboli that commonly originates from the heart. That is also like as a result of, it could be fat globule, it could also be a regular blood clots, especially in patients that have pre-existing heart conditions, valvular diseases. This could come and then lodge in pre-existing areas of stenosis in the brain. Then alcohol intake. Alcohol intake, mild to moderate drinking carries a slightly lower risk of stroke. Meanwhile, for people who tend to take a lot of alcohol, it predisposes you to stroke. So basically, the more alcohol you take, the more you're likely to come down with a stroke. Then clinically relevant anatomy. This is to explain what basically happens at the brain. At the base of the brain, the carotid and the vertebrobasilar arteries form a circle of communication known as circle of Willis. So from this circle, there are other arteries. There is the anterior cerebral artery, there is the middle cerebral artery, and there is the posterior cerebral artery. All these travel to different parts of the brain. There is the diagram. Shaded in yellow is the anterior cerebral artery, the red is the middle cerebral artery, and the blue is the posterior cerebral artery. Then this is also a diagram of the different functions of the different parts of the cerebellum, which is what is affected when a stroke happens. Then strokes can present in predetermined syndromes, the effect of decreased blood flow to particular areas. So for example, you can, when it comes to the different arteries, there are different pre-existing symptoms that indicate that this is what is going on here. So for the left superficial division, the right face and the upper arm motor weakness happens due to motor cortex. Then there's a non-fluent aphasia due to damage to the Broca's area, what we medically refer to as Broca's aphasia. Basically, Broca's aphasia means the person can make like words, coherent words, but forming like a long line of sentence becomes an issue. Then there will also be like right face and arm cortical sensory loss in some cases when it involves the sensory cortex. Then other deficits also include what we call a Wernicke's aphasia. That is when it is severe. For the Wernicke's aphasia, basically they can't form coherent words. They tend to like make incoherent like statements, things that when you string them together, they don't make any sense. Then there is the right middle MCA superficial division. That's the left face and arm upper motor weakness due to damage to the motor cortex. If you notice here, the left superficial division leads to damage to the right side, while the right division leads to damage to the left side. The left face and upper arm motor weakness due to damage to motor cortex, and there is left hemiparesis that happens due to damage to non-dominant association areas. There may also be the left face and arm sensory loss if it involves the sensory cortex. Then, when it involves the left lenticulostrate branches, that is the right pure upper motor hemiparesis due to damage to the basal ganglia. So basically, there is weakness on the arm. And then there is also, when the infarct extends to the cortex, it may also produce deficits such as aphasia, like I mentioned earlier. Then there is also the left MCA lenticulostrate branches. That is basically the opposite of the other one. It's in the right, so it affects the left upper motor, and there's hemiparesis due to damage to the basal ganglia and the internal capsule on the right side. And when this infarct also affects the cortex, it can also lead to aphasia. Then there is the left PCA, which is the posterior artery. There's what we call right homonymous hemianopia, which is basically a visual field loss in the same halves of the visual field of which I correct. Like, for example, the visual field loss is on the right side in the right eye, like this side. Then it also means that in the right side of the left eye, which is basically this side, there will also be like a visual loss. So there's a visual loss on this side, right side of the right eye, and also a visual loss on the right side of the left eye. That is what homonymous hemianopia refers to. So that can happen when the damage to the left posterior artery, and then larger damage can also lead to hemisensory loss. That is sensory loss on one part of the body, and hemiparesis too on the right side because it's on the left posterior artery, so it's on the opposite side, due to disruption of the ascending and descending information passing through these structures. Then, for the right posterior artery, it's the opposite of the previous one. The left homonymous hemianopia now happens. So basically, it means there is damage to the left part of the eye on the left side and the left part of the eye on the right side. That happens when this affects the right posterior artery. Then when there's larger let's say damage, yes, because it can also lead to hemisensory loss, that is loss on one part of the body, and left hemiparesis due to disruption of the ascending and descending information passing through these structures. Then for the left anterior artery, the right upper motor neuron, there's right upper motor neuron weakness due to damage to the motor cortex, and the frontal lobe, there's a behavioral abnormalities, and there can be like aphasia can also be seen because there is damage to the prefrontal cortex and supplemental motor areas. Then for the right anterior artery, it's the opposite of the other one. The left upper motor neuron weakness happens, which affects the left leg. And then there is a grasp reflex is lost, so the patient can't grab. Then there's also like hemiparesis on one side. So basically, the summary of all these things, I know it was a lot of mumbo jumbo, is, for example, if stroke happens, and it affects the left artery. The left side of the body is not what is damaged, it's the right side of the body, because basically it's like an opposite thing. The left part controls the right, while the right part controls the left. So if there is damage to the left arteries, it means the body part coming down with what we call hemiparesis, that is with weakness of one side, and the sensory loss in situations where the sensory cortex is affected. So if it's the left artery, then the right side of the body is experiencing difficulties. But if it's the right artery, then the left part of the body is experiencing difficulties. So basically, it's like an alternate thing. Then clinical presentation of stroke. There are different things. Hand dysfunction is a very predominant one, where the person can't grasp. Because there's weakness already, so there's a lot of things going on. So the hand dysfunction is a sign. There's changes in muscle tone. There is altered muscle power. Definitely, someone who has come down with a stroke on that side, the muscle power, we have the muscle power grading, which is graded from 0 to 5, 1 to 5. So like 5 means that is your normal functioning muscle power for 5. You can move against resistance. But people who have come down with stroke most times cannot have a muscle power of 5. Then there is weakness. There is a coordination problem. Little things you could do like button, pick a pen becomes difficult for a lot of stroke patients. Changes in sensation, but those are the sensory cortex is involved. Not everybody, they come down with changes in sensation. So there's like an altered sensation. Some might be able to feel light touch. Then, but for some people, some might be able to feel deep touch. When you actually like go in, they can feel that, but they can't feel the light sensation. While for some people, they cannot be able to feel anything at all. Then subluxation actually happens in some people who come down with stroke. Basically, subluxation is a minor, or let me say an incomplete dislocation, because the joint surfaces are still touching, but they are not in normal relation to each other. Whereas in dislocation, the joints are no longer like touching. So like a subluxation is like a minor dislocation because the joint surfaces are still touching, but they're not in normal relation to each other. Then there's also what movements of a joint and other body parts. So a contracture basically means like the way we are, our body is free to move and everything. But when a contracture sets in, it becomes an issue to do normal things that you could do before, because there's been a tightening of the tissues and muscles and everything surrounding that place. And it also elicits pain when you try to do the said movements. Stiff muscles, like I just explained, because of the contracture. Overactive reflexes is also a sign. And then the hemiparesis, paralysis on one side of the body, whichever one. Then the visual, there is a blurred vision, that is the vision is blurred, basically. Double vision sometimes, sudden visual loss, or temporary loss of vision in one eye. That is also a sign of stroke. Then the whole body, there is fatigue, there's lightheadedness, and there is vertigo. Basically, vertigo is when you have that feeling of like you want to fall. Then sensory, pins and needles. Whoever is coming down with stroke tends to develop these signs of like there's a pins and needles sensation coming down. Sometimes it's a reduced sensation of touch. You could touch them, but they might not feel it if it's a light touch. You have to go in deeper for it to elicit sensation. There is the facial symptom, that is muscle weakness or numbness. So basically, you see some stroke patients coming down with like one weakness on one part of the face. So basically, they won't be able to like do the normal like raising of the eyebrows, tilting the lips to one side. Those are like the minor signs, and then you can tell that something is going on. Then the limbs, numbness or weakness, that is like a classic sign. Remember I said if it's happening in the left artery, then the right side of the body is experiencing weakness. If it's happening to the right side, the right artery, then the left side of the body is experiencing weakness. Other signs are also the balance disorder, difficulty swallowing, there can be headache, inability to understand, there's mental confusion, and so on and so forth. Differential diagnosis. This is basically things that tend to look like stroke but are not actually stroke. Things that you can mistake to be stroke based on having similar signs and symptoms. That is what differential diagnosis is referring to. So first on the list is what we call a transient ischemic attack, TIA. Basically, a TIA can actually be a sign of a future stroke because it basically exhibits most of the symptoms that stroke comes with. But the difference is most patients who come down with TIA actually get like pick up in some cases, some 24 hours, some 48 hours. So a TIA is a stroke-like attack. It can resolve within minutes to hours. Some people resolve within minutes, but it still requires immediate medical attention. And remember, I said it can be a sign of a warning sign of a future stroke. Then another differential diagnosis is metabolic derangements like hypoglycemia and hyponatremia. Hypoglycemia basically is low blood sugar. Low blood sugar is, I know we're all running away from high blood sugar. Nobody wants to have a lot of sugar to predispose you to diabetes, which is actually good. But let's not overdo it in these cases that we now come down with low blood sugar because they are actually more, will I say, more debilitating than the high blood sugar. So in low blood sugar, like the sugar level is low, that's the body's main source of energy. And next thing, the person can actually come down with some of the signs and symptoms of stroke, the dizziness, the weakness, and all that. Then there is also, and some diabetes treatments can actually cause hypoglycemia, that's low blood sugar. Because the person has, for someone who has diabetes now, the person constantly takes his or her medications. Sometimes, maybe taking too much of these medications, or maybe like trying to caution the diet and trying to reduce the sugar level, can now reduce it so bad that you start having hypoglycemia. So that is also like a triggering sign for, and kind of a differential diagnosis for stroke. Then sometimes certain infections can actually like mimic stroke symptoms, especially if it's a brain infection. Then sometimes brain tumors too can actually mimic the symptoms of stroke. And also hemiplegic migraines, they can actually mimic the signs of stroke. Hemiplegic migraine is a headache, but it's characterized by motor weakness affecting only one side of the body. Hence the hemiplegic there. It's a migraine, a headache, a severe headache, but then it comes down with paralysis of one part of the body. So that can also be a differential diagnosis for stroke because the symptoms are sort of similar. Then the hyponatremia, that is when there is a low sodium level in the blood. We know too much sodium is bad, but too little of it too is also not good. That is a hyponatremia. So when someone has a low sodium level in the blood, that can also lead to some of the symptoms of stroke that we see, and it's also a debilitating like situation too. So in as much as we're all trying to stay healthy, eat healthy, limit this, limit that, let's also be conscious not to limit too much that we now predispose ourselves to a whole lot of other things. Then here, the early management of acute stroke. Basically, when it comes to the management of stroke, it's a multidisciplinary approach. The doctors are involved, the nurses are involved, the physiotherapists are involved. It's an all hands on deck situation. One medical team alone is not enough to do what is required here. So basically, the goal for acute management is to stabilize the patient if rehabilitation is to take place in a different ward from acute care, the care received should be made as seamless as possible. The type and intensity of therapy should be determined by the patient's needs, like I said earlier. Primary goals of rehabilitation are three. First and foremost is to prevent complications. There's already a damage. The most important thing here is to not prevent further complications. Second one is to minimize impairment. The damage has been done, so let's try to minimize what's going on. Then maximize function, because basically stroke patients, the key thing is they are losing function, whether sensory or motor. So it's to maximize function, which is the most important goal. Now, optimizing post-stroke rehabilitation. Now, we've spoken about the position. Remember, the patient lies on the unaffected side with the affected side up, the head slightly elevated to increase blood flow. Basically, what happens when a stroke happens? The human brain does not know body parts. The human brain, what it knows is movements. So that is why whatever movements you're used to doing, the brain kind of like registers it as this is my norm, this is what I do. So the human brain knows function, not body parts. Well, the cerebellum that is in charge of movement, basically, you know what I'm referring to. It knows movements, not body parts. So now, when a stroke happens, the part that is affected, the brain is trying to forget that this part exists. So that's why you see them, most times they're trying to use the unaffected side, because naturally that is the one they are already prone to using because of what the signals the brain is sending. So while this person has to be positioned in such a way that the affected part is up, is to trigger the person to use that part, for the brain to remember that this part exists. So the person is positioned on the unaffected side. So the person is forced to use the affected side. Then early assessment with evaluations and assessment tools is key for you to get your muscle power, the muscle tone, and all the information you need. There's also early employment of evidence-based interventions. Different interventions have happened that have been known to, like, some people say mirror therapy, some people say game therapy. So it depends on what the physiotherapist and the person wants to go for. Then ongoing medical management of risk factors and comorbidities. Now, the aims of the treatment, first and foremost, is to manage pain effectively. Stroke patients are in pain, whether it's from the tightening of the muscles or other things. So pain management is key. Now, also, be selective when choosing compensatory versus remedial intervention. Some interventions are remedial, that basically they are trying to maximize functions and improve the patient's outcome, while some are predicted to have a low, for patients, some patients have a low return of motor function. So there are some prognosis you see, and you know that this is not going to be an easy work. So there are what we call remedial interventions, and some are just compensatory, just to compensate the major ones. So it's to know how to plan your treatment to involve the remedial interventions and the compensatory ones. Then patients who come down with poor functional use of the arm and hand. Mind you, when it comes to stroke patients, the lower limbs recover faster. So most times you could be stuck dealing with the upper limb for a while. That is where the remedially focused rehabilitation actually comes in. Then use measures of no reliability and evidence for planning outcome prediction. In cases with severe impairments or poor prognosis for recovery, treatment should focus on maintaining a comfortable, pain-free, mobile arm and hand. For those who come down with like severe impairment, where there's like so much contracture, there's spasticity, the treatment is to maintain a pain-free. Remember, that is the primary goal, to minimize pain, comfortable, pain-free, and mobility, to maximize function, to be able to mobilize the arm and the hand over and over. Focus on proper positioning to provide support and rest, and careful handling during functional activities. The positioning I spoke about, remember, to lie on the unaffected side, and the affected side is up, and slightly elevates the head. And then also careful in handling during functional activities. When you're attending to the patient, you should note and also be careful not to actually like elicit more pain. Maybe you're trying to like do certain movements. Then participate in classes supervised by rehabilitation clinicians. That's basically to enhance your own knowledge, to participate in classes and rehabilitation techniques to actually like help include motion exercises to maximize functions. Then also avoid the use of overhead pulleys. Sometimes you'd see, I've seen some places, okay, one time a stroke patient was being rehabilitated and he was made to use an overhead pulley in as much as it could help to maximize the function of the upper limb. There's a risk of shoulder tissue injury. So like overhead pulleys should be avoided as much as possible. Then some means of external support for the upper limb during transfers and mobility. For example, when the person is trying to, I'll still show some of these things. When the person is trying to like sit to stand or lying to sitting, some support should be administered for the upper limb. And then the arm and the hand should be placed in a variety of positions from time to time. Remember, the brain doesn't remember body parts, it remembers movements. So the arm and the hands should be moved from time to time so that the brain also starts to remember that this particular movement is actually something it's used to do. That is where the passive mobilization comes in and the soft tissue mobilization and all that. And the hand should also be placed within the client's visual field, basically. So they can also see and be forced to use the hand. Then also engage in repetitive and intense use of like novel tasks that the patient used to do before the stroke happens. Try to involve them as much as possible. Some theories have stated that gaming actually helps to improve like upper limb functions. That is something that can be incorporated into the treatment mechanisms, and also functional tasks and activities, minor things. Also engage in motor learning, including the use of imagery like pictures and videos. Those also come in handy. Now, the treatment techniques, there is the strength training, basically to increase muscle power. And now there's evidence that this limb strength and function without increasing tone or pain. So that's the goal here, to increase strength training basically aims at improving limb strength and function without increasing tone or pain in individuals with stroke. Strength training is your normal strengthening exercises, just minor ones. It could be you could do RAE, like I said, I'll also show some of these things here. Then there's also the CIMT, constraint-induced movement therapy, where you can bind, for example, let's say the left is where the weakness happened. So you bind the right arm to the body so that the person is forced to use the left arm because that is what is free. That's the constraint-induced movement therapy. Some studies suggest that performing aerobic exercise prior to CIMT enhances the outcomes. Then gaming, like I said before, some people say gaming actually helps to improve upper motor function. Apart from the upper motor function, it also helps to improve the brain function and also like re-educates the brain on certain things. Then there's also the mirror therapy, doing certain exercises in front of the mirror to actually like help the patient, like the visual field, to see what he or she is doing. It helps the patient to actually like do more because they can see that, okay, I'm not really doing this properly. Then there's also the virtual reality. This is a theory that some people have proposed that virtual reality training also helps patients to improve function. Then the enhancing healthcare team outcomes. The prevention and management of stroke are best done with an interprofessional team approach. Like I said, it's a multidisciplinary stuff. It's not a one team thing. The doctors, the nurses, the physiotherapists, even the radiographers are involved. It's not a one-person thing. During the time-dependent early stroke phase, stroke care involves an optional team to manage the disease. Now, evidence revealed that hospitals with stroke teams have decreased mortality and improved outcomes. So once a diagnosis of stroke is made and accurately treated, the patient may need extensive physical rehabilitation, speech therapy, dietary consult, all these things come in handy. And then there is also those who recover function within 3 months. The prognosis is good. Then for those who have residual neurological deficits, the outcome is a bit guarded and they may need more extensive treatment. Nurses and physical therapists at this point play a crucial role because they also have to educate caregivers, family members on the situation at hand and how activities of daily living of this person may be a challenge and how much assistance they can render to the person. Now, secondary prevention after an acute stroke depends on the underlying stroke mechanism. If it was caused by high blood pressure, then interventions have to come in to reduce the blood pressure, change the diet, keep the person more rested and active in the right situations. Then also, if it's maybe high cholesterol, if dietitian can be involved to actually like plan meals that would contain less cholesterol so that there is no repeats of the said situation. Management of stroke is actually one of the most difficult and challenging issues for health professionals. Then it is only through the interprofessional team approach that the best outcome is achieved. So I'm going to be demonstrating some positions and some exercises and how to help stroke patients, like from lying to sitting, sitting to standing, some little things and some other things that can actually be of help. So we're going to start with positioning. So we're going to, let's say this is the part that is affected. So she's going to, first and foremost, when you want to help, so she's seated here. So first and foremost, she has to lie. And then use a pillow to elevate. And then the legs come up. While the pillow is used to elevate the head to improve blood flow. So this arm can rest on a pillow. Another pillow is kept, and she can place the arm on it. And that way it's in the visual field. And this affected side is up. And then sometimes when she wants to do something, she'll be forced to use that part. So this is what we mean. Exactly. Then if there's another pillow, you can place that here. And then this one is placed on top. And she can always like use this from time to time. And then the leg, the pillow is placed in between here vertically. So that is for the positioning. Remember, the affected side is the one on top, while the head is elevated to improve blood flow. So now, when it comes to this patient coming, sitting, when you got into the part where, for now, when the patient is in this state, when all he or she can do is lie and the muscle power is not so, when the muscle power is not so good, that is when we do mostly the soft tissue mobilization in the form of massage and the passive mobilizations. So the passive mobilizations basically tend to help this patient remember the normal movements that we do that sometimes we used to take for granted. There is your wrist flexion and extension. And there is also for the leg, there is also like an ankle, the flexion, and the extension. And then also, there is also the abduction and the adduction. And then when the patient has, let me say, like gotten better at this, and then you're now trying to train for sitting. So from lying to sitting, the person is like this. First and foremost, the person is trained to take the legs outside. And then from there, this hand is used, this hand is a good hand. So she can place this hand. And then you assist here, and then we try to come up. So she uses this one as a form of support. You try to assist like this, and that's how we get to sitting. When your patient is able to get to sitting, you can incorporate auto-assisted exercises where the person is made to hold these arms together. So you have to assist with the other hand that you know is not so good. So when she's able to get this here, the aim of this is to use this one that is unaffected to help this one. So basically she uses this to pull the other one. She's doing it herself, that's why it's called auto-assisted. And then she brings it down. So basically, this one is key to help me return like the function here. So she uses this to pull this up for the upper arm. And then when you're able to get your patient to do this, it's a gradual process. In and out, as we're saying, this can take months to achieve. So when you're able to get this, next thing you're trying to train for is sitting to standing. And that is when this patient who was able to do the auto-assisted, now the person is sitting, the person pulls herself up with this, and then you assist from this side, and the person is able to stand up. The first time the person stands up, you have to make sure, even subsequent times, at least for a while, someone should be at the back, someone should be by the side, because there might be orthostatic hypertension, basically because this person has not stood in a very long time. So you have to stabilize the person, probably count 1 to 10, and then she sits back. And then after that, you can do another repetition. You can do 3, the second one she stands, you count 1 to 10, third time. And then as time goes on, you can progress and increase the time of standing. Another thing when when you're preparing patient to stand is she's seated like this. The lower limbs now, you get her to this one that is weak. She tries to raise this and raise this simultaneously. She does this and does this. She can do 20 of it. You count to 20, she takes a rest, and then another 20. This prepares her to stand, and this also helps to prepare to walk. So when you're able to get the person to stand, remember I said we're saying this, but it doesn't mean this happens in a space of weeks. This could literally take months. So you could be doing STM, passive mobilization, for a very long time, possibly like months, before you get to the time when the person is able to sit. And then when the person is able to sit, you could be training the back muscles and everything, and you're trying to train all of them. That could also take another month before you're able to get to the position where you're like, okay, you can sit now, let's train for standing. So stroke rehabilitation literally takes a whole lot of time. But if we're able to employ the time is brain concept of where this happened, everything is done like fast, everything is, the response is fast, there's actually a good prognosis. I've seen patients recover like in a matter of months because the time is brain concept was involved. But when maybe the stroke happened and this person has gone weeks and there was no physiotherapy, it becomes a problem because then contracture has set in, spasticity has set in. The prognosis now, it takes a longer time to even get to just the person able to move and the sitting position and all that. So when we're able to get the person to stand, the person has to learn to stand for a while before you even attempt walking. So different strength exercises can be done on the bicycle, ergometer, with the sandbags, and all of that strength exercises to actually improve the muscle power. The way your patient is finally able to do the sit to stand, when you're able to sit to stand, then remember the standing. When she comes up, you're assisting here, and she's able to stand and you hold. That is for the standing. So when you've been able to achieve this, and with the matching in place that you have done while sitting, you can start the matching in place while standing. So now you hold the person while the person tries to match in place while standing. That is in preparation for walking. Mind, remember, like I said, this can take a very long process. So after you've been able to get to this, patients can now attempt to take little steps, just very little steps, like front and back, and then back again, and then front and back, and it's a gradual process. And then when you've gotten to this level, that's when the balance and coordination comes in, because they've lost the use of balance and coordination. You can then bring in, there is the finger to nose, where you try to do this to this. So where you try to do so there's the Okay, so basically the balance and coordination exercise is there's a finger to use to train for fine motor movements like buttoning of shirts and zipping and little things. And there's also the finger to finger where you try to pinpoint different fingers. And then for patients who you've gotten to be able to stand, you can do the tandem walking where they try to walk with each feet in front of the other. And then there is also there is also the other balance and coordination where you get the step climbing, where they take a step and then they take one down. This is good because this can actually help to train for strength and also for coordination. Another thing you can do when you're trying to see get your patient to sit is the breathing exercise. So for them, these patients now can just lie. So for the bridging, your patient is lying facing up supine. So the knees are folded this way. The patient's arm are relaxed by the side. At first, for patients whose muscle power is still at 1 or 2, it's going to be assisted breathing in the sense that you're the one doing the lifting. You're the one doing the lifting, and then you breathe down. Then as the muscle power increases, the patient can do that for herself. So she comes up and then she goes down. And then you can also go for a sustained stretch of it where she comes up, and then you count to 10 while she's there before she takes it down. That's like a modified bridging position. Then also to include the lower limbs to strengthen it. Let's say, remember this was the weak side. So to strengthen this weak one now, she's going to do this bridging while she raises this leg. So you're coming, yes, exactly. So she can do this, and then you count to 10, and then she brings it down again. This is also like a training for you to be able to get to train the back muscles. And then another thing you can do is in sitting, when your patient is able to sit, you can also do a stretch where, remember, this is the affected side and this is the unaffected side. So you're trying to do a stretch, and then I'm trying to go this way. Then you can do a count to 10 or a count to 20, depending on which is convenient for you. And there's also the stretch this way, just to train the back muscles for sitting and standing. So there's also other myriad of exercises and strengthening techniques you can do, depending on the muscle power and level of coordination that your patient is at. Each treatment technique, each treatment modalities depends on your own choice, depends on what you want to use, depends on the patient's position, depends on the patient's level, the prognosis. All these things are things you look at in planning your treatment care for stroke patients. So that is the end of our slides and the presentation, and the questions can come in. Okay, we have two questions here. How does the subarachnoid hemorrhagic stroke differ from an intracerebral hemorrhagic stroke? Okay, so the intracerebral hemorrhagic stroke, remember I said that one is a bursting of the arteries and the blood vessels in the brain and in the basically like in the brain. But the subarachnoid one is like in between the Okay, so the difference between the intracerebral hemorrhagic stroke is that there's a bleeding from a blood vessel within the brain. And remember, the high blood pressure is the cause of this because the major artery actually bursts within the brain. While the subarachnoid hemorrhagic stroke, the blood vessel that is bleeding is between the surface of the brain and the arachnoid tissue that cover the brain. So it's on the surface of the brain and the arachnoid tissue covering the brain. It is not like inside or within the brain. That is the difference. The next question. Okay, so now question is, what occurs when a hemorrhagic stroke takes place? Okay, a hemorrhagic stroke, most times it's caused by high blood pressure, not all the time, but most times. So basically, when the force of the pressure on the artery walls are too much, it's like it's consistently hitting on it, it ruptures. That is a hemorrhagic stroke, the rupturing of these blood vessels. So that's what happens there. The blood vessel ruptures, and that's what causes the stroke. Basically, that's the hemorrhagic stroke. Remember, the ischemic one, there's a clotting of the blood artery. Something comes there and blocks it, and the blood can't flow. But hemorrhagic, the blood vessel bursts. That's why the major cause of this one is the high blood pressure. Because of the pressure of the walls, the pressure of the blood of the artery walls, that's basically the cause of the hemorrhagic stroke. Okay, two more questions. How does the presence of atherosclerosis affect the prognosis and treatment options for stroke patients? Okay, basically, for people who have atherosclerosis, which could be as a result of blood clots, like fat globules, that is where, remember I said it's a multidisciplinary approach. So the dietitians come in, this person has to have a planned diet or maybe reduced, whatever is the cause. If it's hyponatremia, reduced sodium. If it's high cholesterol, reduce cholesterol, so that this does not happen again. And then in the event that this has already happened and the arteriosclerosis has happened, the healthcare providers, the doctors they come in and they give the medication they're supposed to give. And after that, we now tend to manage in the sense that you have to make sure that you don't move certain body parts, so you don't dislodge any other possible blood clots until this patient has gotten to a certain level, until the doctor gives declare that, okay, we don't have the possibility of this happening again. So it means that passive mobilization has to be done very carefully here. And any other movement that is being done has to be done very, 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 very carefully. And the dietitian has to be involved to make sure the diet is changed and there is no possibility of this happening again, even while treatment is in process.
Okay, and the second one, the third one, so the first question, sorry. What's the role of atherosclerosis in the development of ischemic stroke?
The role of atherosclerosis, basically, like I said, it's fat globules, blood clots that form and they occlude these blood vessels. That is, they block the blood vessels. And ischemic stroke is as a result of blockage of blood vessels. So basically, atherosclerosis leads to ischemic stroke because these blood clots and these fat globules that have formed, some of them are formed in the arteries in the brain and they clot the arteries there. Some may be formed in other parts of the body, and then they actually move to the brain and still cause an ischemic stroke there. Then on the Zoom, we have a comment here saying, thank you, many should understand there is hope for stroke survivors. Yes. Stroke basically does not mean like it's a death sentence. Remember the time is brain concept I spoke about. When stroke is attended to immediately, the prognosis is good. When all the health people, when all the teams that are supposed to be involved is involved, the prognosis is good. Another thing is education. You'd hear some people say the stroke happened and the physiotherapist was involved a month after. You don't go a whole month as a stroke survivor and not go for physical therapy. When you go to like hospitals that understand the need for this, most times the referrals are sent after these things have been administered. Even when the Glasgow Coma scale is showing maybe 8 or less than in the comatose patients, physiotherapists come in, and that's when you do STM and passive mobilization to make sure that these body parts are moving, to make sure that these body parts are functional, so that the brain doesn't forget them. So even for comatose patients, even for physiotherapists go to the ICU to see these patients, so that someone is maybe comatose or unresponsive, not like dead, comatose or like not really responding, does not mean the therapy should not be involved. You call the physical therapist, and that is when PM and STM is done, so that when this person does become responsive, you don't have things like adhesions and contractures forming. So basically, that is it. For stroke, time is brain. So basically, when it comes to stroke, someone is having a stroke, remember the do's and the don'ts. You don't give aspirin and you don't give them things to drink. And then remember the do's, where you check the breathing for those who are unconscious. If there's no pulse, you start to do CPR if you know how to do CPR. So like, basically, we have to try to get this person to a healthcare facility for the right thing to be done. And then for those in the healthcare, the physio should be involved as early as possible, because that is the key to actually getting this person back on their feet. Okay, also, so basically, since that's all the questions we have, so I would like to thank each and every client, our patients, our friends, our families, and everyone who voted for us. Last week, Friday, we won the Nigerian Healthcare Award for Best Physiotherapy Service Provider of the Year. And we won this award too last year. So that's 2 years, 2 concurrent years. So I mean, that means we're doing something right. So once thank everybody who voted for us, everybody who shared our pages and all that. Thank you for your votes. Thank you for always coming to us with your concerns, with your needs, and we'll keep on giving you the best of service because we're the best in Nigeria now. So thank you. And I would also want to use this to emphasize that we also have facilities for inpatients. We have one in Victoria Island, Lagos. For people who want to receive treatment but they don't live around, we have in Victoria Island, Lagos, we have in Warimpa, Abuja, we have in Wuse to Abuja. For those who want to receive treatment but they live far, you can actually come in and then you register with the inpatient facility. It's fully equipped. you're cared for, everything you need is there, and you get your treatment, and after you can go home. So thank you once again for your votes. Thank you once again for always keeping us in business. And thank you for tuning into the webinar amidst all the technical glitches we had. Thank you, and we hope to see you soon.